Okay, I think we'll go ahead and get started. Good afternoon or good morning to everybody. This is Stephanie Hall. I'm with the ESRD NCC, and welcome to our Reducing Hospitalizations, Emergency Visits, and Readmissions Learning and Action Network. We're so happy you could be here today. We're very excited about our presentation, and we want to jump right into it so we have enough time for Q&A. So just a few meeting logistics before we get started. This call is being recorded. Everybody who has come into this meeting is on mute, but we do want to hear from you. So as I mentioned, there'll be time for some Q&A. You can drop questions or comments into the chat during the presentation or at the end. So we do want to ask you to share any of your thoughts or ask any questions. So what are some best ways to spread what you hear today from the LAN? You're going to listen and share your approaches and experiences via the chat. You can identify how shared information can be used at your facility. And we ask that you apply at least one idea from today's LAN at your facility and commit to sharing your learnings with other colleagues. And with that, it's my pleasure to introduce our speaker today. Dr. Landry is a private practice nephrologist working for Kidney Care and Transplant Services of New England, a group composed of 14 nephrologists, transplant vascular access surgeons, and advanced practitioners located in Springfield, Massachusetts. He currently also serves as the chair of the Medical Review Board for the ESRD Network 1 and is president-elect for the National Forum of ESRD Networks. Dr. Landry's clinical and research interests include population health and value-based care delivery models, as well as efforts to improve the education of our next generation of nephrology physicians and advanced practice providers. So please welcome Dr. Landry. And Dr. Landry, let me pass the ball over to you.
Terrific. Thanks, Stephanie. I really appreciate it. Yeah, okay. I think I officially have control.
You should.
Wonderful. Thank you. And again, thank you for this very kind invitation. I've always loved working with you, of course, Stephanie, and everyone for the National Coordinating Center, and I appreciate the opportunity just to share some thoughts today with the group regarding transitions of care. I'm not sure if many people here run into physicians who say they're kind of excited about this part of their practice, but I really am, and I see a great value to all of this here. So I'm going to go through this with everyone in terms of just sharing some of my thoughts. A few cases I think might be indicative of experiences I think a lot of us see throughout our different walks of care of patients with kidney disease. And again, certainly, as Stephanie mentioned, happy to answer any questions or just open up a good discussion at the end of today. So as far as today's talk goes, I wanted to offer a few goals that I thought would be kind of worthwhile addressing. First of which is to define the adverse outcomes that are associated with emergency department visits in utilization for patients with end-stage kidney disease or end-stage renal disease, and what are different ways we can approach this in terms of trying to help provide safe diversions when possible. We're also going to talk and describe the varied opportunities for involving timely and safe transitions of care through the hospital and rehab setting. There's so many different levels of transitions of care I think everyone realizes and appreciates, but ultimately we're certainly focused on just improving the best care we can for our patients and trying to prevent adverse outcomes like unnecessary readmissions. I also, as I mentioned, was going to share some, or will share some personal experiences from our outpatient dialysis clinic, as well as on the inpatient realm, where I also spend a great deal of time in a large academic medical center, and some of the lessons I've learned from that, as well as my work in value-based care. And then I also want to make sure that at the end of the day, we can provide dialysis facilities and those working there with some of the best practices that we can hopefully try to implement and provide resources to help support you to do so. So I'm going to start off with a situation, a scenario that, as I mentioned, I think probably everybody here is fairly familiar with and taking care of patients with kidney disease throughout their careers. But it's a Monday morning. And there's a 62-year-old male who's a dialysis patient coming to the emergency department with a complaint of shortness of breath. And he's been on in-center dialysis every Monday, Wednesday, Friday for the last 3 months because he has diabetic kidney disease. And he's been coming to his treatments regularly. He's, I'm not always crazy about the phrase of compliance because I think that can be misinterpreted or used against people in adverse ways. But he comes to all of his treatments. He seems to be making every effort he can to do the best he can, and it seems like things have been going relatively well there. But they do usually remove quite a bit of fluid during his treatment. And in even the short period of time he's been on dialysis, he's not voiding much urine anymore. So dialysis is really his one opportunity, as you know, to get rid of that fluid. And during his last treatment on Friday, he left about 1 kilogram above his target weight because his blood pressure dropped a bit. He started cramping, and they had to give a little fluid back. And then he said, over the weekend, as he showed up in the emergency room, he said it was a hot weekend. And so I probably did drink a little more fluid than usual. And, going back through the records, it's notable that he didn't unfortunately receive a lot of pre-dialysis nephrology care leading up to all this. He started with a catheter, as many of our patients do, now has a fistula, but nevertheless, there were opportunities that were probably missed from that perspective. So in the emergency department, he's afebrile, he has no signs of pneumonia, or viral testing is negative. He does have clear evidence of volume overload, although he's saturating well on room air, and he's in no acute distress. And this is what happens next. And this is something that I recognized long ago, and I think everyone here has as well, that oftentimes in healthcare systems, for the sake of what people believe to be efficiency, they go to the easiest direction and oftentimes don't do what's best for our patients and the healthcare system as a whole. And what happened in this situation here was that the emergency room or emergency department provider says, you know what, today is the day for his dialysis. Why don't I just go ahead and call the hospital medicine doctor and let's get this person admitted to the hospital, and then we'll get him dialyzed later. Out of sight, out of mind, and I have other patients to take care of. Later on, nephrology is made aware of this patient about an hour or two later, and asked, hey, the patient's been admitted. They're not going anywhere now, so could you please arrange for dialysis? And, as oftentimes is the case, the dialysis unit's full. So we were not able to get him dialyzed until later on that night, actually. He gets an abbreviated treatment, not the full treatment we'd like to, provide our patients. And he's made a 24-hour observation stay now, rather than having just been potentially, transitioned out of the emergency department. But now that 24-hour stay actually turns into a 2-day stay because of a medication error with insulin. He got hypoglycemic, and it took a while to kind of get things settled from the sequelae of hypoglycemia. So this is kind of how we so commonly see what seems like a relatively quote unquote kind of simple problem turn into a real complex one, and one that leads to a lot of morbidity and sometimes mortality for our dialysis patients. So here are some of the opportunities that I came across, or thought of, I should say, as I was kind of putting this case together. And again, it wasn't really even putting the case together because it's just something I've seen, hundreds of times in my career. First of all, if we kind of just go in order of this patient's entry into nephrology care over time, he never really had any pre-dialysis care. And when you don't have that, you oftentimes don't get the conversations and even just repetitive conversations about watching fluid intake, sodium intake, getting someone prepared for dialysis. Because as we all know, patients who start with catheters, not only are they at higher risk for infections, but oftentimes they don't get as good at cleaning. And of course, when we're pulling a lot of fluid, that's when we start to see patients also lose quite a bit of their residual kidney function. And that, of course, leads to patients who really, really have a tough time getting through the weekend in particular. And then, of course, there's a topic of, education of our patients in terms of saying, if something is to happen, if you don't feel you can come to dialysis this morning, please contact us. Let us know what's going on so we can stay in the loop and maybe we can actually help you. And how many times do we come into a scenario where the patients don't do that? They kind of panic, and I can appreciate that as well. And they panic and they go straight to the emergency department. And of course, when it comes to recognizing social determinants and drivers of health in the socioeconomic disadvantage nature of many of our patients with end-stage kidney disease, we know that there is essentially kind of a culture that's built into many of our patients where they go to the emergency department for routine and even semi-urgent care, when oftentimes maybe a phone call to the dialysis clinic could have helped a patient in terms of either coming in earlier on a different day, realizing this was a Monday morning, sometimes too also just triaging something and helping the patient receive the care that they need and maybe help avoid unnecessary emergency department visits. And then, of course, the last thing I just want to mention is, what are different ways to improve, communication between the emergency department? Once these patients, that's obviously the first point of entry, the first people are going to see these patients typically, and nephrology, because oftentimes the emergency department providers, they communicate quite readily with hospital physicians and have patients admitted to the hospital, like in this case here. But at the same point, we're not always the first call. And when we're not the first call, then we don't have that opportunity to intervene and help out like we could have. So what if we did a bit of a do-over? What if we, did a Groundhog Day or something and tried to do over and said the same patient with the same presentation, but in terms of the subsequent events, maybe the first thing the ER provider does, recognizing this patient does need some care through dialysis, is not necessarily reflexively go for an admission to the hospital service, but actually calls the nephrology team. And then what happens next is that the nephrology provider comes down, sees the patient rapidly, and then determines that actually, this patient doesn't have an oxygen requirement. They're not critically ill or in a place where we probably couldn't safely just get them out to their dialysis clinic and get them dialyzed safely and avoid unnecessary admission to the hospital. And then what happens is the nephrologist does contact the outpatient charge nurse. Charge nurse, he says, sure, we actually have a time today at 11 a.m. Why don't you get them over here as soon as you can, and we'll get this settled. And in our community, with a lot of our brother or sister clinics, we also know too that if maybe the home clinic for our patient was unable to take care of the patient, we will check around to see if other sister or, like I said, brother clinics will be able to take this patient for this one treatment. In which case, in this scenario here, the emergency department case manager arranges a ride share and gets that patient over to the dialysis unit. And at the end of the day, what happens? Well, the emergency department and the hospital wins for avoiding an unnecessary admission. The inpatient and outpatient dialysis clinics win by having that patient to care for and have the people around them that know the patient best. And most importantly, the patient wins, right? Because they avoid not only all the trouble that we see with people going through the emergency department, but of course, all the other morbidity that associates with patients who end up coming into the hospital. And I want to share that information with you now. So this is a study from JAMA Internal Medicine published in 2016, looking at Medicare claims data from 2005 to 2011. And what you're looking at here is different characteristics of end-stage renal disease patients and emergency department utilization. And if you follow things along from left to right, you'll actually see that what they're doing is looking at data for a patient who's in their first year of end-stage renal disease, their second, their third, fourth, and fifth year of being on dialysis. And a couple of things I want to point out and highlight to the group here, which I think is fairly informative and also a bit, a little scary, to say the least. Take a look, first of all, at the mean number of emergency department visits per person year for this dialysis population, national dialysis population in the United States. That essentially, even though we know, as I'll show you in the next highlight, how we recognize that mortality is higher in the first year for patients who develop end-stage renal disease. In this study here, we actually see that throughout their time, they're actually consistently showing an elevated number, 2.5 to 3 mean emergency department visits per year. Okay, I mean that's a lot of ER visits, obviously, for any individual. And if you also take a look, you'll see that in terms of mortality, yes, in that first year, as I mentioned, it is highest. But at the same point, there still is mortality associated in patients who are showing up to the emergency department. And if you take a look at what percentage of patients who show up in the emergency department end up being admitted to the hospital, it's nearly 50%. So we're essentially talking about a coin flip for our dialysis patients when they reach the emergency department of whether or not they're going to be admitted. One other study I just want to share with the group was one that was published. Actually, oh, forgive me. Before I go to the next one, actually, this is still from this first study. A couple of things actually I want to also mention that the most common admission diagnoses. Now, if you notice, number 2 is septicemia. I think most of us would probably agree that if you come to the emergency department septic, you probably ought to come into the hospital. We have some things to take care of, and I would say I'd be fairly comfortable with accepting that. But if we take a look at hemodialysis access complications being the main source of patients coming to the emergency department, and the third one being volume overload, or what's been typically just kind of labeled as congestive heart failure, those are things that we absolutely have control over, right? And that goes through better nephrology care and things that we're trying to help improve every day, whether it be through value-based care models or other areas, but we still have a long, long ways to go. Patients with the ESRD utilize the emergency department 6-fold and 4-fold higher than national mean rates for US adults and Medicare beneficiaries, respectively, okay? So just having end-stage renal disease, which we know is such a great burden for our patients, poses an incredibly high risk of emergency department utilization, and yet also a lot of preventable scenarios here too, okay? And we know that, as I mentioned earlier, with the socioeconomic disadvantagement of our patients and different drivers for social determinants of health, we know that their access to care in the community is oftentimes very limited as well. And that's where we recognize that in the emergency, or excuse me, in the dialysis clinic is oftentimes that place where we provide a lot of that care and support. And of course, the most strong predictor of emergency department use occurred in patients who had hemodialysis central venous catheters. So yet again, the bane of our patients' existence and ours too, we know that pre-dialysis care, education, patient activation, right, to improvements in health literacy, you name it, all those different areas can only help our patients, give them a better opportunity to make sure that they don't have or end up in these high-risk situations. So here's the other study I wanted to mention. This was published by Wong in 2021 from BMC Emergency Medicine. And this was an analysis of ER utilization, ESRD data for adults 18 years of age and older from 2014 to 2016. And this was provided by a registry called the National Hospital Ambulatory Medical Care Survey. Okay. Again, similar numbers, approximately over 700,000 out of nearly 93 million annual ER visits, or nearly 8% were ESRD patients, okay? Disproportionate to what you'd expect here, no question. Males being more likely to be ESRD patients than females, and non-Hispanic Black, 2.5 times more likely to have ESRD compared to whites, as well as Hispanic patients, 2.68 times more likely. And if you take a look at emergency department patients with end-stage renal disease, they were more likely to be admitted to the hospital, as I shared with you in the other study as well as the intensive care unit, okay? As well as receive more blood work, more radiology tests. And we think about those things. Those are not benign situations, right? We know that these patients are certainly at a higher risk and may need a lot of these tests, but many of them, of course, just get these tests reflexively. How many times do we injure veins and potentially sacrifice future AV access, not to mention end up with testing that might lead us down pathways that we never would have gone, and now put patients into a scenario where they're receiving excessive care, but they really didn't need. So again, I think yet just another study showing that. And as we talk about many different areas of ways to try to help improve care at site of delivery, and particularly ER utilization. One thing that we've implemented personally, and I wanted to kind of share with the group, was actually an advanced practice provider driven service here at our hospital in the nephrology section. And what we've done is we've incorporated advanced practitioners into our inpatient rounding service, which might be very commonplace to some of you here today, and for others may not be at all. In the nephrology community, I've seen that I think we're still learning how to best work with and utilize advanced practice providers. And I think that's so critically important that we really expand these opportunities to these providers who are so critically helpful and important. And what I have seen early on in my career oftentimes was utilization for dialysis rounding in outpatient clinics, but now has really expanded to so many other areas of care. And I think that not only helps improve the care for our patients, but also gives the APP, more responsibility, more exposure, more enjoyment, frankly, in terms of a career which has, so many different things to look forward to when it comes to nephrology care. So in our service, as I mentioned, we have advanced practice providers who are part of the inpatient nephrology rounding service. They're also embedded with the emergency department in such a way that they're well known. They're known by first name to our emergency department staff. And they know that they can call Anne, they can call Giovanni, and they can call any time to say, hey, listen, I've got one of your patients here. Could you please come down and take a look, because I want to know if there's anything we can do to help, avoid a hospital admission. I think they look well enough where maybe they don't need to stay here. And this is how we actually help educate our emergency department providers as well. And by doing so, we can provide rapid assessments and communicate with our local dialysis clinics and allow our advanced practitioners to also function at their highest level and really make a major impact on the healthcare system and to our patients. So that's, like I said, one thing that I just felt was really important to share with the group, because it's something that for me and for my group, we found to be incredibly helpful. And it's something that everybody wins. I want to kind of segue now just briefly into something where you may ask exactly why I've put this here today, but I wanted to talk just briefly about value-based care and the Advancing American Kidney Health Initiative that was created back in 2019. It's a value-based care has been here in nephrology since back in 2004 when the bundled payment system came into play. But then following that, my group and others were involved in things called seamless care organizations, or ESCOs. Some of you might remember that. And nowadays we've kind of evolved to the next generation of models. And what we're trying to do here is institute improved care for our patients, while at the same time also trying to be thoughtful about reining in the cost of care, which we know is so high. In doing so by essentially trying to approach these main principal goals: reducing the incidence of end-stage renal disease, as well as making sure that the majority of our incident ESRD patients are either going to receive a transplant or going for home therapy if possible, and then really increasing the number of kidneys available for transplantation. And you see here's different percentages and time frame metrics, some of which you can look at and say, there's no way we're going to be reaching those, and that's probably true. But at the same point, I think some of these things, while aspirational, at least were good goals to set for the community in order to really push us to do better by our patients and by society. And you also notice too, the secondary goals in terms of encouraging the development of artificial kidney through more research, and then restructuring payment models to really incentivize prevention, home dialysis, transplantation. But at the end of the day, this all really adds up to improving the quality of care and doing so in a way that's more cost effective. And if you kind of look at this beautiful summary slide that was put together by one of our past presidents from the National Forum of ESRD Networks, Dr. Andy Howard, if you look right now in the center part of your screen, the Kidney Care Choices model is the model that many nephrology providers are now involved in throughout this country. And these are voluntary payment models for which some are involved in something called Kidney Care First, others involved in something called the Comprehensive Kidney Care Contracting Model. Say that 10 times fast. But the bottom line is that, without boring people with too many details today, there's many nephrologists and nephrology providers who are involved in this right now. And if you take a look down the bottom of the screen, some of the major areas of focus are areas such as patient activation, like I mentioned earlier, in terms of helping our patients really take better control of their own care. Because we know that a patient who is more engaged in their own care is more apt to call the dialysis unit to say, hey, I'm not feeling so well this morning. What do you think I should do? Rather than just driving straight to the emergency department or calling an ambulance sometimes. And likewise, improving health equity plans in approaching things from trying to delay progression. And then if you also take a look to the far right side of the screen, you'll see something here called the IOTA model, or increasing organ transplant access. And I bring that up because it's a care model which is not actually active just yet. It's supposed to actually begin in July of 2025. And this is going to be, as you see here, kidney transplant centric. That's going to involve a lot of kidney care providers, as well as transplant centers. But take a look at in the bottom part here in terms of quality measures, and you'll see care transitions. So I bring this up to the group because I think it's important to share with everyone and to think kind of globally, to think from a population health perspective, as well as continue to take care of our individual patients, and to say, right now, this is a major part of what we're doing. And I can guarantee everybody here today that many nephrologists out there are involved in some of these models and don't even realize it, or don't really feel that they're really necessarily playing a major role every day, and yet their practices are. And I think as we continue to push for education and ongoing engagement in these types of models, I'm going to remain optimistic that I think we're going to see some positive change. Whoops, excuse me. Here we go. So, and I just wanted to briefly share that the first year of the model outcomes data was just recently published from the Lewin group it was brought in through CMS. Here we go. And from the University of Michigan. And what they, again, the kidney care value-based payment model is really trying to do is trying to reduce the cost of care while improving the quality of care. All right. And that's the, I think, most important takeaway from all this here. And if you take a look at model year one, you may walk away from this kind of disappointed, as we have with some other value-based payment systems in the past. And yet I also would say too that in year one, I think it's a little early yet. I still have a lot of optimism because I've seen a lot of positive change locally and speaking with other people. But you do see some positive things, as I mentioned, such as improved home dialysis utilization. But at the same point, we didn't necessarily see at this stage of the game really improvement in terms of payment effect. But again, I think if we're doing the right thing by patients and getting them better outcomes, the payment stuff can come down the road. I think first things first is we just got to do a better job at providing better care for our patients. And as you can see here, in the first year of the model, we didn't actually see emergency department utilization or hospitalization improved. Now, if we looked at my own personal data in my own group, we did see some improvement there. But I think that this is where education is such an important thing in the nephrology community, because when it comes to participating in these different models, you're given a lot of freedom to do a lot of different things in terms of what you see fit in terms of improving the care of your patients. And the one example I shared with everybody here a few minutes ago in terms of the advanced practitioner approach in our hospital system is something that's worked really well for us. Maybe it won't work well for others, but I think trying to innovate off of some of these ideas and sharing some of these ideas, like we do at the forum with highly effective practices, I think is one way that actually we can share our success stories, as well as share some of our failures to succeed, maybe stories, and see what we can do to actually help improve the quality of care for our patients. And to that end, you'll see that there were some improvements in optimal ESRD starts in the model so far. But in terms of different improvements in transplantation rates, not just yet. Waitlist status improved, but transplantation rates, not just yet. I'm optimistic that we'll see more improvements as years go on, but at least I think for the first year to get our feet wet in these voluntary payment models, I think was a good step. So let me transition now, no pun intended, to our next and last case study, where we have, again, another Monday morning, but this time I'm already in the hospital, and I'm visiting with Mrs. Singh, who was admitted to the hospital 2 weeks earlier with pneumonia. And she's a 46-year-old patient. She's been on peritoneal dialysis for 4 years, very happy with that, really enjoys that for her, that control, the ability to be home, and also work. And at the same point, she unfortunately did have this pneumonia and had a hospital course, which was rocky. It was complicated by acute respiratory failure. She was briefly, in the ICU on a mechanical ventilation. Thankfully has come through all that, but is really, as you can imagine, wiped out. She's weakened. She's going to need physical therapy, and to such an extent that it didn't appear that she was probably going to be strong enough to get therapy at home. So things are working towards the idea and concept that she's going to need to go to rehab for a little while. And, because of that, I will share with the group here, and maybe many of you are experiencing similar problems that I've heard on prior, discussions, but we don't right now have any local rehab centers that can offer peritoneal dialysis. And when we run into these situations, oftentimes our patients do need to temporarily transition to hemodialysis. And of course, to do so, many of them don't have backup fistulas. They're also getting central line placement as well. And that's what happened in this scenario here. And what happened was the case manager at the hospital worked with the case manager at rehab to arrange for a transfer. The nephrologist was contacted that Monday afternoon, and say, hey, just so you know, Mrs. Singh is going to be heading over to rehab tonight or tomorrow morning. And it caught the provider a little off guard. But because that rehab in this setting here doesn't actually offer hemodialysis, the patient's also going to be transported to their dialysis, to a dialysis clinic. She ended up going to the in-center side of her home therapy unit because they have both there. But this in-center had to scramble to find and accommodate a spot for her. And at the end of the day, there never was actually any great deal of conversation that same day from provider to provider, or for that matter, from nephrology provider to patient, regarding discharge plans from a nephrology perspective, medications to expect and needed, dialysis goals. I mean, this is a big deal, right? To have to change someone over to hemodialysis. She had never been on hemodialysis before. So what happened as a result of that? Well, there were different EMRs. The dialysis clinic never received the discharge paperwork in time. The patient actually missed several doses of vancomycin. There was never any conversation with the patient regarding, her ultimate modality goals and helping her to understand too that we hope this is just a temporary need until you're back on your feet, literally, and feeling better. And then the patient, unfortunately, gets readmitted 2 weeks later with a fever and has septic arthritis. So thankfully, this is not a commonplace scenario, but unfortunately, I still think it happens all too often. And, I think when we look at the different missed opportunities here, we clearly, I think, always have to start with communication. And we're lacking communication clear from provider to provider, provider to patient. We had a failure to keep the nephrologist updated regarding disposition planning. Did anyone actually ask the patient what she wanted and what to expect? This was not obviously part of all of the trauma that she's been through over the last 2 weeks. Now having to convert off of peritoneal dialysis, I would imagine would be quite a shock too. She's suffered major losses, right? Modality, independence, control at the end of the day, which is obviously the biggest thing that so many of our dialysis patients and kidney patients are losing during these events. And then, what sometimes we often refer to as those other things or, oh, by the ways, are really critical. I mean, so critical that, that we have, the people that our dialysis patient has known so well, depends on, our social workers, our dietitians, the transportation piece of things, the medication changes. What about trying to figure out what's the new dry weight for our patient, new dialysis prescription? And of course, as I mentioned earlier, the ongoing challenges we're facing with lack of peritoneal dialysis support in a lot of rehab settings. So, again, I offer the idea of saying, what if we had a do-over here? What if we did actually improve the patient communication first and foremost, and helping Mrs. Singh understand the big picture of what's going on? And that, believe me, while we absolutely never wanted to change anything that you enjoy, that you're finding as the best opportunity for you, right now, because of the needs for rehab, I do want to ask if we could convert you, please, over to hemodialysis for a temporary period of time, because we simply don't have a local place who can care for you through the rehab setting for PD. Again, many areas of opportunity there as well, don't get me wrong, but at least in the current setting, many places, that is the situation. Working with an inpatient multidisciplinary team, and they were willing in this new scenario, willing to keep the nephrologist in the mix and get that person involved from the get-go to say, hey, here's what's happening day by day. For us around here, I've really lobbied heavily to kind of actually have case managers who tend to be more geographically located in our big hospital system. And I'm still really trying hard to see if we can get a case manager who can be solely linked to the dialysis patients and not geographically located. So it's still a wish on my wish list, but something I'm working on. In this, do over, the nephrology provider gives clear instructions to the dialysis unit for orders, including the antibiotics, of course, and where we're going to be heading in a plan to get the patient back to PD, make sure the catheter is being flushed, all those important things, reconciling medications, getting discharge summaries over. And then, of course, this contact between the hospital clinic or case manager and the dialysis social worker and the rehab team. And, more recently, what we've instituted, particularly on our home dialysis unit side, are some readmission huddles, so that any of our home therapy patients, that the team in the home therapy unit is doing that huddle where they're actually reviewing things together to figure out where are the weak spots, where are the places where our patient is at highest risk for having problems. And I think that's really important to think about. It's worked really well for us. And again, as I mentioned, I think areas where we're continuing to work on, I've been successful in terms of getting hemodialysis at a local rehab facility, which has been incredibly successful. And our next step come the beginning of 2025 is to bring peritoneal dialysis over too. And I hope that really, really helps. You figure from first and foremost from a patient care perspective, but also too from the perspective of, you look at hospitals and length of stay issues that they're challenged with. Any patient who's converting over modality is going to be leading towards increased length of stay. And I think we can do a lot to help prevent that. So there's many different, not many publications out there in terms of transitions of care in patients with kidney failure. We know, as I mentioned earlier, that not only hospital admission rates are high, but also readmission rates are incredibly high. And of course, the medical complexity of our dialysis patients and kidney patients is on average much higher than the average patient out there. And we know that, as we mentioned in the beginning of the talk today, that there's many different forms of transitions of care that occur in our patients' lives. And they go through so many different emotions, from discomfort and pain, feelings of being overwhelmed, lack of understanding. Sometimes just the sheer physical illness leads to the inability to really process things well until they're really well dialyzed. And of course, there's many different experiences that patients go through where they actually lose faith in their providers because things like this happen, where they say, why didn't you communicate with me? Why didn't you let me know what was going to happen? And so I think there's so many different areas that we can improve upon. And that's where, I wanted to share with the group here today, at the National Forum of ESRD Networks, where of course our networks funnel through. We've created different toolkits over the years, and one of which was the Transitions of Care toolkit that was published just in 2022, in an effort to really hopefully help you and help other people out there address the multitude of different care transitions that occur in our patients' lives. If just to share with the group here that these are all free to access, they're PDF format. Please share with people as you please. And and one of the things I've offered to people over time is to say, find a chapter that maybe is important. Maybe that's something worth sharing with your colleagues. As you can see, we've made multiple or published different professional toolkits over the years. We're currently actively engaged in putting together a health equity toolkit we hope to have done by the end of the year, and more recently updated our home dialysis toolkit. But the Transition to Care toolkit is one that I think is really helpful, and it really addresses, as you can see here in this table of contents, a lot of different care transitions. And we're talking about, of course, for patients who are just starting dialysis. What about patients who are experiencing changes in staff, like we see so often nowadays? Modality changes, not to mention the care transitions like we're talking about here today that occur through the hospital setting and rehab setting. I think oftentimes too, of course, many of us take care of pediatric patients who are transitioning to adult care. So in this toolkit, we try to address a lot of these different scenarios. We have the patient perspective, which is involved here, and we offer some different problem-solving approaches as well. And here is just to share with you some different templates, for instance, that are available here. in terms of, hospital to dialysis unit transfer summaries, post-hospitalization checklist, med recs, even a sample patient form for transient patients who are coming to your unit to make sure that we're not missing things. So I think that there's a lot that's available here to you that's worth at least considering and looking at. As an example here, as I mentioned, chapter 5, in terms of the first dialysis treatments and how we're trying to approach that with our patients. I know for many people out there nowadays, we're using transitional care scenarios, which are terrific. But even for those places that don't have that, there's still a lot of opportunity to help improve these new ESRD transitions. Also looking at, as I said, modality changes, that the post-hospitalization checklist, and then different problem-solving processes, such as the PDSA cycle and performance improvement projects, which I know we're always looking to see what we can try to really provide interventions for. So anyways, I think those are the kinds of things I want to share with you from that perspective. And I think as we kind of come to the end of this talk, I will move along to just kind of the last few slides. The health equity piece is something that is in press, and will be coming soon for more for others to see. But I think that as we kind of try to wrap this together and hopefully entertain some really good discussion here, I think that emergency department visits for our dialysis patients are unfortunately very common. And while I think there's many different things we can absolutely do to help prevent this culture of emergency department utilization, I think we all realize too that to some degree, some of that still is entrenched in our system, and not that we have to accept that, but I think there's also ways to approach our patients at the emergency department level as well, and ways to try to help avoid unnecessary admissions. Education, whether it be in our hospital or with our emergency department colleagues for early interventions, diversion strategies really work. They do. And I think investing that time, investing the people power, but the energy, it pays off. And I got to tell you that I've seen it, personally, and I think it really is a win for everybody involved. Certainly the patient education piece, which again, I do go back to the topic of whether you're using our transition to care toolkit or some other educational material, is something which is so critical in empowering our patients to know that we're there for them and that we want them. We want to be that first call. We want to know if you're not feeling well enough. I mean, if there's emergency, there's emergency. Do what you got to do. But I mean, I think if there's ever questions or anything coming up, please contact us at the dialysis clinic. Let us know what's going on so we can help you. And a lot of times, again, I think we can help avoid some unnecessary healthcare utilization, which can be really dangerous to our patients. Communication, of course, between dialysis clinics and hospitals is critical, in that there's a need for increased awareness of the social drivers of health for our patients in ways, as I mentioned, to really improve patient activation and engagement. And we certainly need to establish better rehab care strategies, which is something, again, I'm kind of actively focused on in our community. And I think is something that is ongoing elsewhere as well. And from a personal perspective, I just also want to leave you with, that investing in quality outcomes, it pays off. And, I think, yes, we'll get to the cost savings at some point. I really do believe that, because I think if we do what's best for our patients, these things will literally and figuratively pay off. But I think right now we have to remember that won't come until we get our quality efforts right. And we've got to keep that focus first. And I think we also need to remember that our nurses, our advanced practitioners, they need to be in a major part of our staffing infrastructure. They provide such incredible patient care, CKD education, continuous dialysis access support, patient activation measures, or PAM, as I describe here, depression measures are things that are really our priority. We call our gateway strategies to in our value-based care model that I'm involved in. And then I think getting really involved more closely with the emergency department, as well as inpatient services, and through case management, I feel is the best place there, are really, I think, going to be areas where we're going to win. if we just put that effort in. Where are we lacking? Clearly, nephrologists. Nephrology education needs to improve. I run a nephrology, education or fellowship here at Baystate Medical Center, and that's I've actually involved a lot of this that we're talking about here today to our fellows. Not standard for nephrology education, as you can imagine. Being a program director, a medical director, are not things that are commonly taught to our nephrology fellows historically. And that's part of the reason why I think we see the problems we're seeing this day and age. So that's something that through the forum, we're trying to improve education that way as well. And I think we all can kind of play a role in, clearly putting more effort behind transitions of care in all aspects in making patient activation, giving them that control is a critical aspect to whatever we're going to do here as well. Better post-acute support, and certainly trying to fight like heck to make sure our patients can maintain the modality that they want, that's best for them. And that ongoing push to help patients perform dialysis modalities that really, really are patient-centered. So that concludes my talk today. I see we still have a little bit of time left, so I didn't go too far, Stephanie, but I really appreciate everyone's time and willingness to listen, and thanks for again having me.
Thank you so much, Dr. Landry. It was a great presentation, a lot of good information. And I just want to, there was a couple comments and things in the chat, and before we get to that, I just have to give, if you haven't had a chance to check out the Transitions of Care toolkit that Dr. Landry referred to, I just really wanted, encourage you to go there, because what I find was really nice about it is they pulled quotes, actual quotes from patients, and then not only were there just quotes, but there was a good part about solutions when a patient says something, and and how to handle those real world time and at the facility level. So I just really wanted to just give them a shout out, because it's a wonderful toolkit. And you do have to kind of just look at it, dissect it, get the pieces and parts that you just really want to, because it is pretty comprehensive. But just go to the sections that really maybe speak to you. So thank you for that. So
thanks, Stephanie. I just was going to say, like I said, that whole communication piece from the patient and all, it really does it resonates, I think, so well, and I think a lot of people will learn a lot from that. Thank you.
Yeah, no, I specifically enjoy that piece. I thought that was a very nice section that you guys added. So just a couple things, and I can look, I've got the chat pulled up. So I know early on Marianne agreed that there is a lack of rehab facilities that take PD patients. I'm not sure where Marianne is from, but I think that's probably not just a specific region in the United States. It's probably a pretty frequent cause. So we hear her pain. So there was it says a major issue I have at my unit is a lack of medical insurance. I have over 25% of the population who are insured, and they go to the ED as a form of primary care needs. Some of them have transportation issues and then missed treatments, and they call 911 to the emergency room for dialysis. So
yeah, all too common, right? I mean, and again, I think we see this all the time. And I did some primary care before I became a kidney doctor, and I have the greatest of respect for primary care doctors, but I think we also recognize too, there's not enough of them out there. Our patients, for many routine areas of care that as nephrologists and nephrology team members, we generally wouldn't consider part of our care responsibilities, we oftentimes do take them on because we know patients have limited access. And I do go back to something I think I mentioned earlier as well, that I think part of that education that we provide our patients who are new to dialysis, and frankly something I think that just needs to be politely reiterated, is to keep us involved in what's going on in your life and in the time. Excuse me, because I think, like I said, a lot of times I've had plenty of patients, as we all have, drive right by their dialysis clinic because they were short of breath and went straight to the emergency department. And, if they had just come to us, we probably could have shuffled things around a bit and taken care of them.
yeah, exactly. And that has brings me to a question that someone sent to me privately in the chat, but they ask, how or what can dialysis facilities do to educate the staff in the hospital EDs about our patients, our dialysis patients?
Yeah, that's a great question. I think, anything that we can do, obviously, to establish communication is critical. I can say that, quite honestly, from the dialysis units that I work closely with, while I've seen some great improvement with communication through, for instance, like our transplant center, which has been terrific. When it comes to the emergency department, we don't have as strong a ties. And frankly, the emergency departments, of course, they're busy. They've got a ton of people who are working in different shift type of work. And it is hard to kind of find, those direct, people to communicate with. I think if there is going to be any opportunity to do that from an outside perspective, like from a dialysis clinic, I think case management is still our way to go. And most emergency departments, particularly if they're big enough nowadays, do actually have a case manager. And the main reason being, I'm sure as most of you know, is because trying to decongest hospital systems has become a major challenge for healthcare systems. It's a patient care issue, it's a cost issue, and if they can help divert patients, they're on board. We're all actually going at this from the same direction, whether we know it or not. So I think if from a dialysis clinic perspective, I think the most constant presence that we can find is the people we want to be communicating with. And I think from a dialysis clinic, that should be case management if they have those people there. And I think from a nephrology perspective, I think it's actually dealing with the emergency department leadership, and that's how I've approached it. And that's where, like I said, but I have somebody who's physically in the hospital setting. You don't, and that's where I think the case manager can really be that person.
Yeah, absolutely. Another person just dropped in, same here, 80% of their population is FES. There is much needed change in the paradigm to stop using the ED as the primary care. But let's see, let me look what else we had. There's a couple other comments I know in there. Having enough case managers is a huge issue. Oftentimes they don't have enough time or too many patients to do the quality of work that they need to do and what's needed. Excellent. Got a lot of kudos. Everybody likes your presentation. There was quite a few people asking about your presentation, and I dropped it in the chat, but just to everybody else, the slides and the recording will be posted to the ESRD NCC website in about 5 business days. That website is esrdncc.org under the professional section. But and please share this out with other of your, many of your colleagues and coworkers if need to be. Let me just look real quick. How are you doing on time? Probably
Stephanie, while you're looking, if there's another question, if I can also just add or reiterate one other thing too, that based upon what you just mentioned, and thank you very much again for having me today. And it's my honor, my pleasure to be here. But I will go back to, I gotta say, I am a firm believer, I think you can tell, if we can actually improve the health literacy of our patients, I think we will go places, and more so than, frankly, any interventions that we ourselves are making, right? Let our patients be the active participants in their care rather than the passive ones, which, we can take some of that responsibility for. And I think when it comes to the issue of health literacy, is clearly we have to continue to dig into finding out what works for our individual patients, right? How do they learn best? Where are their needs? And, I realize that people in dialysis clinics these days, we have many different areas and important pieces of data to track. But I think as we do continue to move forward and find ways to improve our patients' health literacy, we'll see that activation, and we'll see people who are going to be more apt to pick up the phone and call us to say, I don't feel so well this morning. What do you think I should do? And I think that is going to be ultimately, I think, one of the biggest ways for us to really, improve this process.
Yeah, and thank you for bringing that up. And I know it was in your slide about patient activation. I know some of the work here at the NCC, we're looking more into that. I think we're going to hear more about it, whether it's through us and the networks and just in the community in general. And in some of the health equity work that we do, it's been sprinkled in. And I think there's going to be more to come about that, more education, more, you know, hopefully something like this in the future that we can hear and spread the word. So I'm glad you brought that up in your slide and brought it up again just now. So, but I do want to be mindful of everybody's time. So I just want to sort of go ahead and wrap it up, and just want to always put in a little of our social media. We always like to, we've got different things posted on there. We're on, we have, gosh, YouTube, X, we're on Facebook, and we're on Instagram. Those are our signs, and if we'd love to have you on there and like us and share share anything on there with your community. We also just want to I know a lot of people ask about CEUs. We do offer CEUs for this. So when this event concludes, you'll be sent an email. It will have two important things on there. We really want to hear your feedback. We really want to know if there's anything we can improve, what we could do different. And so there is a very short feedback survey. We ask that you take it, and also included in that email, you'll find the links to the CEUs. So that information is on there. If you still having any trouble with the links, just email the NCC at the email up there, and we can certainly help you. And I think that is the end. So again, Dr. Landry, thank you so much for this wonderful presentation today. It was really great. We hope all of our participants are able to take away something that they can implement within their facilities, you know, pretty easily. We appreciate everybody taking time out of your day to be here with us. Thank you so much. If there's anything we can do, reach out to us again at the NCC info at hsag.com. Thank you again, and take care. And this concludes our call for today. Thank you again. Thank you, Dr. Landry.
Thanks, everyone. Thank you, Stephanie.